Okay, good morning and welcome to the Thomson Rogers Current Event Series, Episode 7. Today's topic is proving brain injury, SPECT scan, case study, and the clinician's role in helping the client on the road to catastrophic determination. I'm going to introduce our large group of panelists in a second, but from my perspective, this topic is very important because what we found since the new catastrophic test came into place in June 2016 is there's a gaping hole for our clients who have mild traumatic brain injury that doesn't necessarily show up on a CT scan or an MRI. And the challenge that we all have is helping these clients access medical rehabilitation benefits and get to a catastrophic determination. And a large part of the challenge has to do with the medical imaging and intracranial pathology, a part of the test under the new definition. So today we have two specialized experts here to talk about SPECT scan and how that may help our clients on the pathway to catastrophic determination in the future. Our two experts are Dr. Manu Mehdiratta and Dr. Robert Tarzwell. We're also joined by Thomson Rogers partners David MacDonald and Robert Ben. So I'm just going to briefly introduce Drs. Mehdiratta and Dr. Tarzwell. If I read you their entire bios, we would use our full 30 minutes. So this is just a Cole's notes. Dr. Mehdiratta is a practicing neurologist at Trillium Health and co-founded the Trillium Brain and Spine Clinic. He is also a part-time assistant professor of neurology at the University of Toronto, and he is involved in teaching in the areas of stroke and concussion. Dr. Tarzwell is a dual certified specialist in psychiatry and nuclear medicine. His practice also includes a focus on addiction medicine and chronic pain. He combines his two specialties to focus on functional brain imaging in psychiatric disorders and the use of brain perfusion.
And so today the plan, Stephen, if I can interrupt this for a second, to go through a case study. And the case study is going to address a particular patient. I'm sorry, there's a little bit of overlap here, but I'll just ask Dr. Mehdiratta if he could help us along to understand a little bit more about SPECT scan and if we could address the case.
And most importantly, he holds the Guinness Book of World Records.
I'm really interested about the Guinness Book of World Records. I can't believe I didn't hear the end of that comment. So, Rob, we really need to hear that before we get to Manu, and then Manu, be very grateful for your comments about SPECT. Sorry, Rob, you're just on mute there for the moment. Sorry.
Oh, yeah. So I participated in the world's longest table hockey match in 2013. 30 hours. The record still stands.
Was someone massaging your legs, Rob? Because I just don't understand how that's possible. 30 hours.
I don't understand either looking back, but by God, somehow we did it.
Thanks to everyone for joining in. Manu, really appreciate both yours and Dr. Rob Tarzwell's time. And Manu, please jump in with your comments. Help us understand SPECT, please.
Sure. So thank you to all of you for attending today and for the introduction, Stephen and David. I don't have any Guinness Book of World Records achievements, but in any case, this is a little bit about my practice. I've been working at Trillium Health Partners since 2008, which is a very busy emergency room in Mississauga. And over the years, I kept seeing the same patients going to the ER. They'd come back in after a mild traumatic brain injury, whether it's a rear ender or a sports collision. They would have headaches, dizziness, memory problems, concentration difficulties, sleep difficulties, emotional problems. And the emerge docs would ask me to see them in my office, and I would follow them over the course of years, and I would slowly see their lives falling apart. They'd lose their job, they'd have difficulty keeping their relationships, they'd have difficulty with their housekeeping and recreational activities. And so, as all of you know, and all of you have seen, these things are real and they cause a lot of trouble for people. So myself and Mina Bashai, who's my business partner, founded a company called iScope Concussion and Pain Centers of Canada, which we've slowly spread across Canada. I did my residency at UBC, so we have a strong presence out in Vancouver and also in Toronto and Mississauga, and we're slowly expanding out to Alberta and Nova Scotia shortly, because there's a large need for treatment for these patients. And one of the problems, though, is proving this injury and showing whether or not there's actually something organic or whether it's psychiatric. We all know that there's other sides that say it's mostly psychiatric. So I want to lead you through a case study where we were successful in showing the injury on brain imaging. As I always say, you know, seek and you shall find. And so we did seek in this case. This is a case where the driver was involved in a motor vehicle accident dated April 4, 2016. The car was hit on the driver's side front door by a car turning right into her vehicle. She hit the curb and the car bounced back to the other vehicle and was dragged. Airbags did not deploy. She's not sure if she hit her head. She did not lose consciousness, but she did report memory missing of the impact. And you would think that that would be something important that our brains would keep. She was dazed following the accident. She called 911, communicated with dispatch, but she was out of it when speaking to her husband and didn't really know what to do. And this is a high functioning person prior to this. She was not taken to the hospital by ambulance because she was awake. She later went to a walk-in clinic due to headaches, neck pain, and back pain. And then she started to develop ongoing difficulties with headache, dizziness, memory, and concentration difficulties. She had a second accident about 2 years later where she was rear-ended in a taxi cab. She doesn't really remember the impact and she was confused and had a memory missing for how she got out of the car. She went to the hospital after. So, of course, everything started after the first accident, but was worse after the second. So when I saw her, she had frequent headaches about 7 days a week, mostly in the back of the head with scalp tenderness. She had many migraine symptoms associated with light sensitivity, sound sensitivity, nausea, and vomiting. And she had visual aura preceding the migraine attacks as well. And she was getting migraines more than 8 days per month. And this is important because it met criteria for chronic migraine, which according to the World Health Organization is the 6th leading cause of disability worldwide. She had numbness and tingling into the second, third, and fourth fingers bilaterally. And she had some worsening on her MRI of the cervical spine. She had low back pain as well, with some numbness and tingling into the left pelvis. She had returned to driving, but she had difficulty with memory and concentration. She had intermittent dizziness and had recurrent falls. And we know that people with one concussion are at higher risk of another one because their balance and vision are affected and they're not sleeping well. She had intermittent ringing in both ears, depression, anxiety, irritability, difficulty with sleeping, and a decreased sense of smell and taste, which can occur due to the olfactory nerve being involved. She was otherwise pretty healthy. She did have that previous concussion in 2016 with that first car accident. She was seeing various specialists and actually had been admitted to the hospital for depression. She won't shower unless someone is home because she's at risk of falling. And she had been working for a fleet management company for about 3 years prior to the accident and has not been able to return to employment, not able to drive, concentration, memory, or ongoing issues. And I think Rob Tarzwell will speak about this, the fact that she had sudden rage, depression, and anxiety, which I think the neuropsychiatrists always found useful. And when we look at the SPECT scan, you'll see maybe why that's the case. And she's, of course, having difficulty with housekeeping, home maintenance, and of course with her recreational activities. This is her physical examination, and I did find things where she had reduced convergence to the left eye, so the left eye was not moving in. She had clear-cut scapular winging on the right, so there was weakness in the right shoulder. She had decreased strength in that area. There was atrophy, which no one had noticed before. And again, if you look, you'll see it, and something that's quite objective. She had a positive Romberg test, so her balance was involved. So these were my diagnoses, and you know, these are classic things that we always see, but how do I prove it? How do I show that this person who has a normal CT scan and a normal MRI of the head has something organic going on? So what we've done is basically started looking a little bit closer at this, and we know that when you have a mild traumatic brain injury, there is a change within the brain chemistry. But of course, we can't go out and do cerebrospinal fluid studies and do lumbar punctures on everybody. So in the United States, this device was developed by the Department of Defense through a $50 million grant. and is actively being used in emergency rooms and by the military in the US, as well as we now have Health Canada access and exclusive rights across Canada, where you look at the brain waves and you're trying to determine if there's evidence of a mild traumatic brain injury on this. And so essentially a CT scan just looks for brain bleeding. That's really what it's good for. You won't see MS, you won't see small strokes, you won't see evidence of mild traumatic brain injury on a CT scan, or for that matter, an MRI. This device looks for functional injuries. So all those symptoms that all of you who are on always hear about, the sleep, the cognitive, the emotional, the sleep, it's designed to look for that pathology. So it comes out either positive or negative for structural injury, and then it gives you a brain function index, which is a function of basically the brain connectivity. So this was our case on the patient I just mentioned. So she was positive here. So it gave me an indication. Again, this is one tool in my toolbox. I'm not going to hang my hat on this, but it's telling me to consider advanced neuroimaging. This person has a lower brain function index than I would expect, and she did some poorly on neurocognitive testing. So the next piece then that we move to is the SPECT scan, because it's telling me to go for advanced neuroimaging. And as I said, CT and MRI are not advanced neuroimaging, they're sort of routine neuroimaging. And so in this case, we did go to the brain SPECT scan, and the brain SPECT scan, just to give you a bit of background on that, and Rob will talk more about it and show you the images. It's something that's very medically recognizable. It looks at blood flow, and you basically are measuring the neurotransmitter dopamine by tracking its binding throughout the brain. And so here's an example of a normal homogeneous blood flow through the brain with increased activity in the back of the brain, which is where vision and vision processing is. So this is normal. And here, of course, is a mild traumatic brain injury, where you see a big hole in the front. And this can persist for years after the injury. As much as we all love football, here's the undersurface of a person who is healthy, and then this is an NFL player who didn't lose consciousness on the field, but has ongoing difficulties associated with this. So basically what I've summarized is that we have a subjective history. I found some objective evidence on my physical examination. I found a positive quantitative EEG. And so then in this case, I move on to the SPECT scan, and I'll show you a quick look at it. But I think Rob would be the person to really talk more about this very exciting new technology. So with that, I'll hand it over to Rob, and we'll look forward to questions at the end.
All right. So I'll share my screen. That's showing up well?
Not yet, Rob.
Oh, you don't see it?
Not yet.
Should be there.
No, I'm sorry. I don't see it on mine anyways.
Okay, let me see what I'm doing wrong.
I see your...
I've actually, can you see it now?
Now we can.
Okay, great. Got to hit the button that actually says share. So I'm Dr. Rob Tarzwell. I'm a nuclear medicine physician and a psychiatrist, as has been mentioned earlier, and just recently started with synoptic medical assessments, but have been in this field for almost a decade. First started publishing my research in about 2012 with an interest particularly in traumatic brain imaging and the psychiatric outcomes related to that. So what is brain perfusion SPECT? It's a nuclear medicine technique where we inject a radio-labeled molecule that has an affinity for a specific organ. In this case, we're interested in the brain. And the material we inject takes advantage of the fact that neurons use glucose as their fuel source. And if you remember from high school biology, the metabolic product of glucose is carbon dioxide and water. And carbon dioxide diffuses out of the neurons, and that causes dilation of local blood vessels. So the brain self-regulates its own blood supply at a very local level. Neurons that need a lot of sugar and oxygen, they're burning hard, they're making more carbon dioxide, dilating blood vessels, and therefore self-recruiting their own blood supply because neurons don't store energy. So our injected material diffuses freely into the neurons, and in areas where the blood vessels are dilated, lots of material gets deposited. Where the blood vessels are not widely dilated, not much material gets deposited. Passes into the neurons, where it gets reduced into an ionic form by intraneuronal chemicals called glutathiones. And this gives us a 3D snapshot of blood flow. And that blood flow is an indirect marker of metabolic activity. We have other nuclear medicine techniques that can directly measure metabolic activity, but with brain perfusion SPECT, we're using blood flow through the brain as what we call a proxy marker or an indirect marker that stands in for metabolic activity. And we're interested in three things: normal metabolism, excess, and then insufficient. And we examine all brain tissue for the presence of these things. And here's an example of what it looks like when we inject our tracer. So it'll be injected into a vein. This is an individual that was injected into a leg vein. And so the tracer hasn't distributed yet. This is the beginning of the process. It makes its way back to central circulation, to the right heart, out to the lungs. And then from there, makes its way back now into the left heart, and it starts moving out the aorta, and you can see it heading up the arteries towards the brain. And here's the neurovasculature that's being imaged here. And then from there, the material will undergo its diffusion across neuronal membranes. Here's another image where there's no rotation, just showing the same picture again. And so when we take our images, we want two things to have happened. We want the material to be in the compartment of interest, which is the neuron, and we want all this activity, this background activity in blood, to have been cleared out. And what we end up with are images like this. And you've probably seen lots of these. This is a slice of an MRI. The patient's lying on their back, their feet are sticking out. So their right side is the viewer's left side. Their left side is the viewer's right side. Now this on your right is a brain perfusion SPECT image. And right beside it here is a color scale showing the level of activity for the part of the brain that we're seeing. So here in the center, this is white matter and a little bit of ventricle. And so we don't expect to see a lot of activity here. Out on the outer rim is the cortex, where we do expect to see a lot of activity. And when we're looking at these images, we're looking for areas where we expect to see activity in traumatic brain injury particularly, but where we don't see any, or what I like to call bites out of the donut. So here's normal activity for reference. This is in kind of the orange-red range, which puts us in the region of the 80th percentile of activity. Here's a nice bite out of the donut, and here's a bite. In fact, you could argue, and I would argue, that there's diminished activity throughout the entire right frontal lobe. MRI looks pretty good. There's some findings here on the MRI. You see these white dots. These are the most prominent ones, so I've marked them. And you see them scattered throughout the white matter that were called non-specific on the MRI report. And you can even see the reflection of those here. So whatever is happening, this white matter is not getting the kind of perfusion that you would expect. So there's something going on that is struggling in terms of its normal activity. And going through the MRI a little more, there's white matter abnormalities here, here, here. The radiologist commented, well, these could reflect, in the right clinical situation, traumatic brain injury. Not much to write home about. But then we turn to our next brain image, which is a little bit lower down. So that first image was near the top of the brain. This is getting near the middle toward structures that are, this is the thalamus, and this is the equivalent of the thalamus here. And then out here we have what are called the basal ganglia, reflected in our SPECT image here and here. And then again, the cortex around the outside. This is where all the neuron cell bodies are doing their work, and the cortex is basically, you can think of it as about the size of a big dinner napkin, but all folded up and bunched up. And if you were to lay it out flat, it has 6 layers of neurons that talk to each other locally. And basically it's a computer, and my job is to try and determine whether the computer is operating functionally with these kinds of tests. And again, here's this decreased activity. Like this is relatively normal. We don't mind that. But here, there's relatively decreased activity out along the edge of the cortex. This is okay as well. That previous diminished activity from above we see here, this is significantly diminished. And one thing that you probably have all noticed without me even mentioning it, there are huge asymmetries. The left thalamus and the left basal ganglia are much more active than the right thalamus and the right basal ganglia. Now, the thalamus's job is it sits on top of the brainstem, and the brainstem sits on top of the pons, which sits on top of the medulla, which sits on top of the spinal cord. And it's the final relay station where all the neurons from your spinal cord synapse, and then there are different circuits called thalamocortical circuits that originate from the thalamus to the cortex. You don't actually have access to what's going on directly in the world. That information goes through your peripheral nerves, your spinal cord, and synapses here, and then a new set of circuitry starts to send that information out to your brain. So you could think of this as like the old-time telephone operator. And what's interesting is there's nothing, I shouldn't say nothing, but there's diminished communication happening between the thalamus and the right frontal lobe and the right basal ganglia. This has just all gone quiet. So this entire right frontal lobe doesn't have normal communication circuits operating. And so when we saw earlier that there were these subtle white matter abnormalities, these are actually having a significant functional impact, because the white matter in your brain is the wiring diagram, or the wires that actually communicate and carry the information from these structures, the thalamus and basal ganglia, out to the cortex. And if you got enough damage to the wires, communication and signals aren't flowing, and it goes quiet. And then over here, for a lot of you, this is probably your first SPECT image. This has actually gone somewhat hyperactive. And we see this a lot. And this is what you could call a compensatory reaction. The brain tries to take over the loss of function and tries to make up for it by becoming hyperactive on the other side to make up for the diminished activity here. But of course, there's some problems in this frontal lobe as well. And it's not enough, the compensation isn't enough to return the individual to normal function. Another thing that we look at is the temporal lobes. So here's the individual's right temporal lobe, looking really good on the MRI. Here's the left temporal lobe. Obviously, of course, these are the eyes. And what do we see on the SPECT scan? Well, just to put in some arrows at the equivalent level. Also, another important structure. In the middle of the temporal lobe, about halfway back, this is where the hippocampus lives. And the hippocampus, it's kind of like a train conductor, and its job is to send memory or information out to be encoded as memory, and then it is able to recall those locations, draw all that information back together, and create a multimodal memory, so involving sight, smell, sound, time, the look of your kid's face. Now take a look at the SPECT scan, and we got some serious problems here. This is the brain perfusion through the right temporal lobe. This is normal. We like to see this kind of green, yellow activity, but what we're seeing here is this green getting down into dusky blue. Same kind of problem over here, not as bad, but there are definitely areas of struggle. Even this is on the low end of normal. Getting to the activity in the region of the hippocampal territory, this is extremely compromised. And so we might wonder if this individual has struggles based on decreased activity in the frontal lobes. We might wonder, does this individual have struggles with working memory? Are they able to hold on to a phone number? are they able to regulate their emotions, or are they subject to poor impulse control and poor emotional regulation?
Rob, just
Yeah.
a quick question. You know, our case, are you able to show some of the images to talk about the depression, rage? Because I think we have 5 minutes left.
Okay.
And
Well, the one other area that can certainly happen is what we refer to as the limbic cortex is in the center of the brain, and you can think of that as the generator of impulse and emotion. And the job of the frontal lobe is to regulate. So here's the gas pedal, and here's the brake. And so this individual, you can see that in addition to the compensatory reaction, there's a hyperactivity that you could think of as this person's all gas, no brakes. So this would go along with the clinical picture of rage and moodiness, as it were, and then poor memory, and then probably, I wouldn't be surprised if there were language difficulties as well, given the level of involvement of the frontal and temporal lobes. So now if we cross-reference with the testing data, here's the individual's Montreal cognitive assessment that was scored 21 out of 30, with deficits in delayed recall, only 2 out of 5, which would support and confirm decreased activity in the hippocampus that we demonstrated. 1 out of 3 for language, which involves frontotemporal circuits. This individual's difficulties were more on the right than on the left. So there's a possibility that this individual's language function lateralizes to the right hemisphere. This test can't determine that. That has to be determined other ways, and 95% of us do lateralize on the left. So there's a question mark on that, but it is interesting that this occurred. And then abstraction, which is a frontal lobe function, there was only 1 out of 2. So you ask somebody, what's similar about a banana and an orange? And they say, well, they're both kinds of fruit. They automatically offer the abstract category. When this person was asked, what's the difference between an eye and an ear? They said, a nose, which is a really concrete answer. They kind of get it because they know that what's similar about a trumpet and a piano is that they're both musical instruments. But it's really unusual for somebody to kind of make that kind of a mistake. And then when we cross-reference with the injury, here was someone who was hit on the driver's side, front corner, by a car turning right, hit the curb, car bounced back into the other vehicle. So there's potentially 3 impacts in that first accident, and then rear-ended while seatbelted. So my conclusion would be that both accidents are jointly sufficient to have likely caused the imaging findings, which are consistent with the testing findings. Over to you.
Rob, Ben, I think that there were some interesting things that I noticed from a legal perspective. Do you have some thoughts you want to share?
Well, I just had 2 questions that came to mind, Dr. Tarzwell, in particular from what you just showed. You know, and it's a 2-part question. 1, how does the medical literature embrace SPECT as a tool for identification of mild traumatic brain injury? And the second part of the question, which really flows from when you showed the MoCA and the mechanism of the accident, what role does corroborative evidence, for example, neuropsychological test findings, occupational therapists, functional observations and documentation, for example, play into confirming what you may find on a SPECT?
Right. So the evidence for SPECT spans back to the early and mid 80s and continues to be researched today. In 2014, myself and a group of collaborators published a review to date looking at traumatic brain perfusion SPECT and traumatic brain injury. We were specifically interested in, okay, what's out there? And over a 2-year period, we winnowed down about 1,100 articles to the 75 that were the most relevant, and published that. And that 6 years later, that continues to be one of the most downloaded articles on neuroimaging in all of PLOS One. So there's a real hunger for this information. And we were able to find that there's no shortage of information, and it continues to get researched. It's specifically mentioned as an indication in procedure guidelines for the Society of Nuclear Medicine and Molecular Imaging and the European Association of Nuclear Medicine. So the natural question is, well, geez, I've been doing personal injury law for years. I've never heard of this. What is this? Why don't I hear about it? And what we were discussing before the call is nuclear medicine is like the RC Cola of cola beverages. Coca-Cola, everybody's heard of. You can't escape it. RC, you might only get it in every fourth 7-Eleven. It's going to be at the back of the fridge, and it really struggles, and you got to constantly advertise it. And this is just what it is to be in a very small field of medicine, that even though we're over here and we're relevant, that doesn't necessarily mean we automatically find each other. But when we do, it can be really helpful in cases like this, because within medicine, often it's like, okay, sure, you showed me that there's a traumatic brain injury. What am I going to do about that now? But in law, where the question is, well, did this head injury cause a traumatic brain injury or not? That question of causation is critical. Brain perfusion SPECT can be really, really helpful in the medical legal arena, vice the clinical arena. Now, your second question, in terms of the corroboration, I think, again, that really lends itself well to establishing causation. SPECT tends to show injuries where you get hit, and those injuries tend to correlate with findings on neuropsychological testing. The MoCA is just a cognitive screen. It's a screen that lightly touches on broad areas of brain function. So it touches on frontal lobe function. It touches on temporal lobes. It captures working memory, delayed recall, abstraction, language. So it does give you a flavor of what's going on in broad domains. But what's much more satisfying is when there's detailed neuropsychological testing, and that can be correlated with specific findings in a set of perfusion images. And there's research support as well, suggesting that the correlations are pretty strong.
And so what I think is interesting too is that, this is something put out by UHN about your brain SPECT scan. So it is covered through the provincial health programs, which I think makes it medically recognizable without doubt. And combined with the GOSE, there's a lot of literature to support SPECT. Both Rob and I have had SPECT accepted at court. And so we feel that the robustness of evidence is really great. So how do you get somebody in for this? Well, in Ontario, we have the iScope concussion and pain clinics. We're a group of 10 neurologists, psychiatry, neuropsychiatry. Rob's part of our group with nuclear medicine and psychiatry, as well as chronic pain. And so, if you go to the Ontario requisition, now we have a nurse practitioner that can see people, but ideally if they can go to their family doctor and tell us, what was the criteria for the concussion, then we're able to see them under OHIP and then go through the channels there too.
Manu, I was going to say, thanks for that information. I would like to know a little bit more about the chance that people might have to refer clients for a SPECT. There are a couple of questions by one of the people watching webinars about how easily can I attain. So your reference to the family doctor or emergency is directly relevant. There's another question, and I just wondered if I can read it now and ask both you, Manu, and Dr. Tarzwell to comment. The question is, how was this patient, and I'm presuming it's talking about the case study there, how was this patient treated? Medications are for headache, mood, etc. Was she a treatment failure? Appreciate your comments in relation to that question. Thank you.
Sure. So I saw her, and of course she had a lot of different symptoms with headaches, sleep disturbance. And so one thing that's important about concussion is that it's physical, cognitive, emotional, and sleep. And of course our group of different people, but she needed Botox, for example, for her chronic migraine. She needed an in-home sleep study. She needed psychiatry. And so all of those different aspects were part of the treatment, along with vestibular physiotherapy and occupational therapy. So really, the most important thing for this treatment is multidisciplinary care, in my opinion.
I appreciate that a lot of the attendees probably have as a large component of their practice treating MTBI clients. And certainly from a legal perspective, we found that there are a number of arbitral decisions and cases which have embraced SPECT as probative in a correlative fashion for establishing MTBI. And certainly there is a wide range of effective research in the literature. We're going to be posting as the notes to this webinar a referral form in relation to perhaps hoping that there will be other clients who will benefit from SPECT scan referrals. We'll also be posting the seminal literature as well as the up-to-date literature, including the American Association of Neurology paper in 2017. And there'll be a list of the cases. Just on rough count, there are about 12 Canadian decisions that I'm counting through our research, and about 14 American decisions which reference SPECT, going back in time to Marcosia, which is an extremely important TBI case as well. We know that normally you set aside, the attendees set aside about 30 minutes today for their education or interesting topics. This has been an extremely interesting topics. I appreciate the closing comments from you, Manu and Dr. Tarzwell. And if there are any other questions, certainly we will answer those after the presentation today if you choose to post those. But it's been a great pleasure to learn. Appreciate if you have any closing comments, Manu or Rob Tarzwell.
I guess from my perspective, thanks very much for hearing me out. It's always nice to get the gospel of SPECT in front of new audiences.
Yeah, I think the key point I would take away from today's presentation is kind of outlined in this American Academy of Neurology paper, where it kind of says that neuromolecular imaging, which is PET and SPECT, has high sensitivity for detection of brain injury and often shows injury when CT and MRI are negative. So there is hope for these patients, and we want to get them the treatment that they deserve. And I think that's the end goal for all of us. So we now have a mechanism to do that. Well,
and your points earlier that I think deserve reference again, that OHIP is providing these services. There is a UHN protocol with respect to MTBI, and SPECT well served the discussion that this is a very robust approach to correlative medicine for establishing MTBI. We hope that this has been helpful. Rob, Ben, appreciate if you have any comments that you'd like to share in closing. You're on mute, Rob, sorry.
No, only to say thank you. And this is an area where we as lawyers are very interested in learning about any kind of new technology that would help our clients get identified as having an injury that might fall within the catastrophic impairment definition, because that is the door that has to be opened before they can access the funding in order to even get the additional treatment that they might need. So from our perspective as lawyers, I think it's very helpful to have tools that can help identify and confirm, even if it's only on a balance of probabilities, the existence of a very real injury that can help these people.
And the great news, thank goodness, is that the literature has continued to evolve from the early 2000s, when there was some question about SPECT's use, into a full embrace of it. So I appreciate it, and I'm sure there'll be a lot of attendees who will be interested in reviewing the article. Steve Birman, appreciate your overall comments in relation to the presentation today.
Yeah, I echo Rob's comments, and I think it's incumbent upon us as lawyers now to hopefully get this technology accepted by the License Appeals Tribunal. Hopefully there'll be a case in the next few months or year or so, and that would be a great thing to see. And I just want to thank our presenters today and remind our audience that the next session will be 2 weeks from today on August the 7th at the same time, and we hope that you'll continue to join us for these sessions.
And I'm sorry that we didn't get to all the questions which are evident there, but we'll endeavor to answer those once we go offline. But we know your time is valuable. Enjoy a sunny day and a wonderful weekend, everyone. Thank you, Mark Hunter, for assisting in relation to this production, and Frank Mastroianni and Alyssa certainly has been integral. So thank you very much all for your time. Enjoy your weekend.
Thanks, everyone.
Thank you.
Bye for now.